It's a pleasure to be here. I have been working in Ireland for a good 10 years. Some of our first international accredited organizations are in Ireland. It's so good to see my friends from the Bonds and BlackRock and Matter Private, and so many of you I feel like I know. The program has advanced a lot, but the early years here in Ireland made me very aware of some key issues that has helped us in interpreting and understanding the standards as they apply in other regulatory environments and other cultures. Some of our first struggles were here in Ireland, and now that we're in 56 countries and over close to 600 accredited and certified organizations, it really was a great start to start working here with you all in Ireland. So I'm going to cover some things that relate not to accreditation per se, and not to home care and long-term care. You've heard presentations on that. My focus will be primarily on hospitals and how we have been rethinking what we do in terms of our mission is to improve the quality and safety of patient care in the international community. So it's not just accreditation. And so we do a lot of reflecting on what's happening. Why hasn't quality and patient safety transformed the world as we thought it would since To Err Is Human was published in 1999? Where are the gaps? And so what I'd like to concentrate on today is some of these gaps that I think are happening in many hospitals and in many countries, and then share some ideas on what we can do to close those gaps, and then give you an example of how there is no universal solutions. The solution to quality and patient safety is going to be very individual to your hospital, and trying to adapt some universal principles. I'll give you an example for hand hygiene. The first point here is the gaps have emerged because global healthcare is changing very rapidly. We have new medical devices, we have new drugs, we have new procedures, we have new types of healthcare providers. So the entire picture is changing. And it takes a while to both assimilate that change, but also position yourself for the next level of changes. So it's thinking out quite a ways to try to prepare yourself with structures and processes and an understanding of quality that you're ready for the continuation of change. And accreditation and standards can help do this, but remember that JCI standards are also made available to the public, and so many countries around the world have adopted some form of the JCI standards. So the standards are an influence both for receiving an accreditation award, but they've been a great influence on the national accrediting bodies around the world, which we're very pleased for. So they can be an effective tool, especially in the absence of a regulatory environment. Now, you heard about the regulatory environment in Australia. There are many countries that have no regulations or very few. Their healthcare organizations aren't even licensed. So there's no public accountability for safety and quality and no on-site inspection process. And in fact, many countries in Europe, they have a frequency of inspection of once. Most countries for fire safety, it's one inspection, they never come back unless there's a fire. So it's a very uneven approach, and I think standards are an effective tool, especially in the absence of a consistent regulatory process. And then change means improving quality and patient safety. It's always a work in progress, and I'll share you a couple of ideas about how that, just in my lifetime, my short lifetime, has changed dramatically when I got into this arena back in the 60s. So some of the gaps that I'm going to share a few slides with you on related to biomedical technology, new infectious diseases, new ways of managing data in hospitals, the fact that we have not made the anticipated patient safety gains that we thought we would, the whole notion of aging populations and chronic disease and shifting workforce competency issues. And then there are unintended consequences frequently, as in Ireland and everywhere else, the resources for healthcare are shrinking, and so you try to get efficiencies out of the system, sometimes at the jeopardy of quality and patient safety. And then the final one I'll just speak to a moment here because I don't have slides later, and that's the poor integration of health professional education and research into the quality mechanisms in a hospital. As most of you know, we've recently added chapters to the hospital standards for academic medical centers. And when we were looking at the need for those standards, we would go out and visit large academic medical centers, and I think St. Vincent's is here, and our first one accredited in Ireland. We're very pleased. But there was some missing pieces to their quality system. You talk to residents out providing the bulk of the care in some of these hospitals, and have you ever had an adverse event? They're unsure of what an adverse event is. How do you report it? Frequent answer, I tell the nurse if I've had a near miss or gave the wrong medication or something. You talk to the quality department, they know nothing about that. They can't take their quality reports and segment it by month to show the influence on adverse events of a new class coming in. They can't segment it by type of resident. You talk to the principal investigators in these large research organizations, and I was talking to one and I said, have you had many adverse events on this protocol that you have in place now? Because you have a lot of inpatients, I've noticed, on this protocol. So I've had over 200 adverse events on this protocol alone. So you go to the quality department and you say, tell me about the 200 adverse events on this research protocol. They don't know what you're talking about, because there's a number in the record, and if there's any kind of an adverse event with a patient, they call the number, it gets reported to the pharmaceutical company, a contract research organization, or the IRB, totally circumvents the quality department. So there's a lot of quality gaps in academic medical centers, and so if you have some research or you are a teaching hospital, look at those standards, because it'll give you some hints about how to make sure your quality data reflects everything that's happening. Well, let's look at some of these advances. The first one is certainly advances in biomedical technology for diagnosis and treatment. You know, the heart valves have been around for a while, artificial hearts. But this man in the middle here has lots of assistive devices, and more patients are getting implantable devices, implantable infusion pumps, and telemetry units to give all kinds of data back to the hospital or into their electronic medical record. I talked to, and I met with Medtronic, one of the biggest manufacturers of these kinds of devices. Their vision of the future was beyond my understanding in terms of what they can implant in a body to regulate certain functions and send the data on a continuous basis anywhere in the world to be monitored. So I think we're on the verge of that, and are we ready for it? And operating theaters are just loaded with new types of equipment. So I love this statement because it is so true. It's back from the Lancet in 1999. But if you would change that date to 2015, it still would be applicable. We're evolving so fast in terms of complexity. Yesterday is always going to seem a little simpler. Well, what are the implications then for all of this new biomedical technology and implantable medical devices and so? Well, the first thing is, I don't know if we qualify our medical practitioners correctly. Do we really have an understanding of the core competencies of somebody who is implanting medical devices? I'm not so sure we do. It's not that common in terms of the privileging checklist. How about all those technicians standing over on the border of the operating theater, sending the signals to those devices to calibrate them during the surgery? I don't think we adequately understand if they are observing infection control practices, what have they been credentialed to do, what can they actually do within the operating theater and should never do, what is their role? I don't think we have a good way to understand that. Simulation labs, robotic surgery, much of that establishment of competency is through simulation labs. And I don't think we have a good way to look at and understand somebody who is doing simulations. How many does it take to be competent? And what's the link then between simulation labs and establishing competency? And what is the relationship of simulation labs to the ongoing understanding of competency? Do you have to go back in and review and demonstrate? And I think now that simulation labs are so common in hospitals for nursing and for medicine and for new technology, we need to better understand how they relate to everything else. Device recall, implantable medical device that I flew from Chicago to India to get. What happens if suddenly I don't think it's working right? Or there's a recall on that device that I got in India as a medical tourist and now I'm back in Chicago. And how about discharge and follow-up processes? We educate patients on how to manage themselves and on new drugs and some assistive devices, but do we have good instructions on what to do if they suddenly think their pacemaker isn't right or something like that? I think our discharge instructions are weak. Training of all the staff on the new uses of technology and preventive servicing of this new technology. It's very unclear when you purchase some enormous new technology whether you've ever had your biomedical people in to say, I can service that or I can't service that, or we don't even have a provider of preventive maintenance for that type of new technology. So there's a lot of implications of simply advanced technology. The second is the emerging infectious disease. We're getting pretty comfortable with the fact that patients pick up bugs in hospitals, but there are going to be a continuous flow of new types of infectious disease. In one of our accredited hospitals in Saudi Arabia, the MERS virus appeared for the first time. And they shut the hospital down and stopped admitting patients. But at that point, the transmission route wasn't even known. So there was just a lot of concern about what to do there. And so we will continue to have infectious diseases that are present throughout society. And remember, as a global world, this MERS came back, as you know, to the UK and to many other countries because you have so many people traveling continuously. It's an enormous problem, just the routine, I say routine, but the common types of infections picked up in the hospital environment. This is US data. I think there's probably similar levels of data in most countries, but in the US, almost 2 million cases of hospital-associated infections, 100,000 deaths, and 35 billion probably now in costs. That's 35 billion out of the system for costs. Countries are beginning to regulate this. In the United States now, if a patient picks up a hospital-acquired infection, the government stops their funding for that patient. That from then on, the care of that patient through that taking care of that infection to discharge is on the back of the hospital. So that there is a regulatory approach. Much of this is related to hand hygiene failure, and I'm going to talk a little bit later about a targeted solution tool to help with hand hygiene, because we haven't made the advances that we hoped we would. So what are the implications? Hand hygiene compliance. The standards say adopt the WHO or other authoritative sources' guidelines. It's not working because they are so hard to adapt and understand, and they're not a fix for all hand hygiene problems. Negative pressure rooms are in short supply around the world. There are HEPA filtration devices but many hospitals don't even have an adequate number of them. And if you look at where these new infections have started, there was massive influx of patients, and the hospitals are not prepared to manage them. So they're having to identify selected hospitals that have enough negative pressure rooms and that can manage large quantities of patients. I was traveling throughout Asia when the SARS hit, and they had triage rooms set up outside of the emergency entrance just so the patients would not even come into the hospital. And they would triage them and send them to other hospitals that had capacity. And so they were totally unprepared. They are now, but they were unprepared back then for the SARS patients. Staff education, how can we keep educating and re-educating and keeping their skills and prevention up? And even compliance with public health directives is lacking in many hospitals. You ask, what kind of directives regarding infectious disease, not only detection but reporting, do you have, and are you in compliance with them? They frequently just can't keep up with it. The next area is that we have made tremendous advances in data use and management. I love this picture. When I started in the 60s in hospitals, this was my computer room. You know, it was in the basement. There was a computer czar who knew everything, who printed out these little lined green sheets that were stacked on everybody's windowsill. Never a division of what do you need to know in these 600 pages of data. You just got the whole printout once a week. And now, you know, you look around your hospital and you've got very small and mobile devices, and people are putting in information and looking for alerts, and you can connect to your inpatient electronic medical record. We are this month testing handheld devices for all of our surveyors so they can enter data in real time right into the database, so we can watch what's happening in your hospital during a survey and what standards are being scored, and become involved in Chicago with it. So all of this is changing. Along with it, the real need to have assurance on the validity of data. Hospitals are being overwhelmed with data and not sure exactly how valid some of it is, even though they're making important patient care and management decisions regarding that. So the implication is we're going to continue to collect a lot of data, but we've got to understand how to set priorities for it. You can't collect everything, but we've got to move up and find the people who are accountable for setting priorities for measurement in a hospital, and then make sure that we do those validity checks. And as I mentioned, accountability has got to be at the leadership level in the C-suite. And as you look at the changing of regulations and standards, more and more we're realizing that things don't go through a complete implementation, and they're not sustainable unless they're supported by the leaders in the organization. Leadership role has changed tremendously along with all of this. And then benchmarking. How do you really find good information in which to benchmark against? And then to standardize care, we have got to get this circular routing of data to the people who are at the bedside. Patient safety has been very slow. This is creating a safe culture is essential if we're going to get any further. And we've heard about the safe culture in the airline industry. In every industry, you have to create a culture where reporting is the norm. This is just a little chart about fear of speaking up, Many people are afraid to talk back. I'm sorry, part of this has got cut off here. But this is also the report by Robert Wachter. This is the 5-year report. He did also a 10-year report that isn't very flattering of the patient safety movement. And one of the notations in the original To Err is Human book was that we need to effect a cultural shift to make safety a top priority. We're not there yet. We are just learning how to measure a culture of safety. We're still not good at changing the culture. Measurement is one thing, and change is very difficult frequently to implement. I was looking for safety culture things. This popped out. I'm sorry I don't have the date, but here was a wrong site surgery because people weren't comfortable in speaking out. And to get this culture, we've got to make some really important shifts. You see at the top there is leadership. It always will be at the top of patient safety. But you've got then healthcare down here, and you need some kind of rapid process improvement, but you also need to trust, report, and improve. This cycle has to be built in to all your quality mechanisms if you're going to shift from down low to high reliability on the right. And I want to come back and mention high reliability in another context too. I like this because it gives what has, from James Reason, which has been the explanation of these harm events for a long time. This is from 91, so almost 20 years now. But high reliability makes a very big change in this. Rather than down here, this last little oval before the event hits the patient, you're back on high reliability up to that very first dark square up there. You're plugging all these holes by high reliability organizations have a safe culture in which they report a lot of events, whether they're connected or not. A staff member comes in with a really bad cold and they're on decongestants. Is an important event. A computer system that's slow that day is an important event. One of the managers that is going to come in late is an important event. Because if you begin to understand how those patterns of very minor events suddenly contribute to a hole in the cheese and start a major event that could cause harm. So high reliable organizations have this kind of sensing throughout all of their work, but that takes a very safe, confident environment supported by leaders. And we're not there yet. So the implications is that we're not going to make gigantic leaps in patient safety unless we have leadership commitment and create a culture of safety in our organizations. And that will produce the reporting and the proactive approach to understanding when there are factors coming together. Now there's some added dimensions here I'd like to point out. Patient safety due diligence for resource purchasing and reallocation decisions. Many hospitals will need to reduce the number of nurses, and they do that in a way without understanding the implications for patient safety when they move nurses around, reallocate them, cut the number on a shift or anything. So those kinds of big management and resource decisions take people who are willing to sit down and talk openly in a safe environment about what are the implications then for patient safety. Buying that new infusion pump that you already have 3 manufacturers represented in your storage room, and the lowest bid comes in from a 4th manufacturer. Quality needs to be sitting there with purchasing and finance to share with them the impact on quality and patient safety of having yet another infusion pump with a different alarm system and different on-off switch. And that takes new training, that takes new capabilities in your preventive maintenance department, all of which can cost more than the difference between that low bid and buying something that you already own. Supply chain management is increasing safety of drugs and drug supplies. I sat down with Johnson & Johnson, Baxter International, Medtronic, Underwriter Laboratories, and I said, when we were thinking about the next edition of the standards, if I could make your industry happy, what would we put in the standards? And they said supply chain management. Because even in the United States, we have counterfeit medical devices creeping in. There are over 7,000 manufacturers of pacemakers, of which only about 20 are legitimate. But they put the label of Medtronic on something that was manufactured in a garage in China. And those are into the distribution system. Johnson & Johnson said China has flooded the international market with fake J&J bandages that aren't even sterile. So understanding the supply chain becomes a very important patient safety problem. And for drugs, the substitution of drugs along the supply chain is enormous. Supply chains where a heat-sensitive drug is stored for a month in customs in an unair-conditioned environment and destroys the drug. You need to understand those things. That's part of patient safety too. It's the next level of understanding where all your critical supplies come from. The next area is the aging of population and chronic disease. The little pointer isn't working here, but oh, there it is. But you can see it's not only in developed countries, but developing countries, enormous explosion in the aging populations, and this is no difference from really the distribution from 2005 in terms of the chronic disease. And so we have to begin to tune up for those types of aging populations and chronic disease. This slide has nothing to do with Ryanair, although it looks a little like their flight pattern. This is the number of communications necessary to discharge a chronic disease patient from a hospital. I don't know how this works. I mean, even with handheld, devices, there are just so many communications that have to take place as we treat more and more elderly patients with chronic disease. So the communication is an enormous challenge for us. So the implications for all of this is that patient assessment and documentation needs to be more patient-centric. The family participation is critical. Patient records and outpatient summaries are essential to these types of communications. Patient and family education needs to be throughout a hospital stay, not just before discharge. The next area quickly is competent workforce. Independent practitioners, your consultants in Ireland, continue to hold the key to good patient outcomes. Establishing competency in the beginning is still critical, and also part of preventing errors when individuals practice at the margin of their competencies. And practitioners may be a block from your hospital. Sometimes now we're dealing with laboratories in other countries. It is now possible to get, if you're crossing time zones, is to send a sample to some other part of the world and get the response back in your time zone before the lab across the street from your hospital even opens up. So all of that is changing with telemedicine. We have people in other countries diagnosing problems, looking at your x-rays, and to be able to understand this in terms of not letting people who are not competent in the area into your system when you're trying to manage a global system in some cases is really confounding. So the whole credentialing, privileging, and review process can't be done every 3 years. It needs to be a continuous flow of information moving from clinical care into understanding when a practitioner is falling outside of the norms of your organization and outside of the norms of the benchmark organizations you're looking at. Your workforce needs to be supported with a good employee health program. You've got new infectious diseases, communicable diseases. We were doing focus groups around the world, and we did one here when we were looking at the new standards. And one thing we heard is from the staff in hospitals, you spend so much time talking about patient safety, what about us? We are getting abused by other patients, we are getting abused by other health professionals, we are getting families who are violent when they come in with a relative. What about our protection? So there needs to be more protection of the workers in terms of immunizations and in terms of understanding where are the likely places in your organization that person-to-person violence could take place. The worst we've heard is we do not go into a certain area of Mexico because of the drug gangs. And we were scheduled to go in the Monterey area and do a triennial survey. And the week before, the drug gangs came into the hospital. They captured 2 surgeons and took them off, got all the blood out of the blood bank and all the medications out of the pharmacy. And off they went. Well, that's not exactly a safe environment for anybody, but understanding that kind of thing and protecting your workforce, that's an extreme example, is really important. Primary source verification of credentials needs to be a more rapid process. We've made some changes in the standards that I think will help facilitate it, but we've shortened down the time. We let you from initial survey to triennial go for 3 years to finish it up. We've condensed that down now to a year. There are still reports of forged credentials around the world. People are working without qualifications, and we need to more rapidly verify those credentials. And then, of course, the good data is needed to support professional practice review. And we've modified all of that in the standards as well. We heard comments this morning about how the healthcare sector is under pressure to reduce costs, do more with less. And so the need for greater efficiency is there today, and it will be there into the future. And so we need to really have a better understanding about how we can efficiently use resources. One way to do that we've introduced in the standards is a requirement now that on one of the hospital's highest priorities for improvement, you do an ROI on that improvement. You figure out the cost, human, computer, other costs, for the current process. You make your improvement and you reestablish the cost. We consider investment in quality an investment. And so most businesses do a return on that investment. And so we've introduced a simple way, and we'll support organizations and expand on this over the years. But you need to start calculating what type of efficiencies are you getting out of all of your investment in quality improvement. And it may always be, or could be, unpredictable. This little graph here, which you can't see, was related to patient dissatisfaction with the waiting time in outpatient care. The solution was hire more clerks. Well, that increased cost, but the patient satisfaction went way up. So you have to understand it's not only financial return, there are other returns on investment, so you need to balance those returns for your organization. So, selection of hospital-wide improvements, and as I mentioned, doing a ROI to understand the impact. In most cases, there will be savings, human resource savings, time savings, dollar savings, euro savings. But you need to be able to demonstrate that so that the leaders and your governance can make informed commitments about continued support and growth of the quality infrastructure in your organization. Well, that's the primary areas, but I want to comment on a couple of other areas. We think of quality and patient safety as kind of slowly evolving. I'll be going to the International Society for Quality in Healthcare later this week and into next week. You hear about a lot of new things there. But I think we need to be sensitive to how quality and patient safety as a field is evolving. Because it is evolving quite rapidly over the last decade, and that needs to influence our structure for patient safety and quality in our organizations. Accounting for the right accountability, and then looking for the next step. Now this back here on the left goes back to the early 60s when I was on a hospital staff, and every Tuesday we got in this meeting room and were given a couple of stale sandwiches and a soda and told to review medical records. Retrospective chart audit. We hated it. What worse is we learn nothing from it. Whatever the results were, they were tabulated, they went into somebody's file just to show that we had a chart audit process. Well, over the years, we've moved to quality assurance. Oh, get rid of them. They were involved in a Sentinel event. Fire everybody. To starting to think about systems, CQI, TQM, and I'm pleased to say we're up here in the more proactive area now with patient safety and eventually high reliability. But throughout this, we've had an enormous array of tools for and lean management and Six Sigma, and quality departments are overwhelmed with the opportunities to use different types of new tools to get them further along this line of improving. Now, who knows what's out here after high reliability? We'll keep sensing other industries. They may provide guidance to that, but we're certainly on that path. So if your quality department is still back there in the CQI, TQM, you may need to try to move up into some of the more recent tools and recent activities. It's all based on shared accountability, and that's where many hospitals are lacking. From governance that improves your quality plan to your C-suite of leaders, right down to department level and to the people at the bedside and ultimately to the patients. And you can see your quality program cuts across all of that. So the quality program takes on new significance in terms of accountability at the governance level all the way to the bedside. And in terms of understanding that full program and integrating it and coordinating it. I don't think I need to back up now, do I? Was that back up to the other slide? Okay. Now, some shifts in management that I think are also important for patient safety. Number one, if you look at the management literature, they all say the 21st century has given rise to workplace democracy. Now, I equate this a little bit with patient safety and the ability to speak your mind, and everybody's thoughts and contributions are valuable, but this is a switch within the management literature in healthcare of away from this command and control hierarchy to workplace democracy. And that has given rise to teams that make decisions, but some of those decisions aren't good, so teams do the analysis of why it went wrong. They do the root cause. They develop strategies to correct it. But also, teams function best when the environment is safe. So to get that shift into a democratic workplace environment, it goes hand in hand with the safe environment for everybody to speak out. And so this is what you see in the literature base for evidence-based management. And what that means to me is that you are making decisions related to patient safety, and all of these decisions, I could give you an example of how they relate to patient safety, but these are typical management decisions. And so how does evidence fit into this? If we're saying evidence-based management, and we say, well, in clinical care, we use a lot of evidence. We have clinical guidelines and protocols and pathways, and we have this all coming from the health professions based upon extensive research, credible research. Is that the same for management? No. Here you've got hypotheses, very controlled studies contributing to clinical evidence, but management evidence is going to come from the data you collect in your organization. So it's very dependent, not on external sources, but on you collecting data to present to the managers who are making decisions. And it's a very, very different process. It's a very introspective process because that data is going to be peculiar to your organization and your situation in the management decision. So these decisions are core business decisions, they're operational decisions, and strategic management decisions. And all of these, when you look at that literature, they give case studies of how those are influenced by data that's in the organization frequently. They don't have to collect new data, but it's assimilating it and presenting it in a way that management decisions can support patient safety. Finally, an example of how closing the quality and patient safety gaps is becoming more and more dependent on very organization-specific solutions rather than on generic solutions. And I'm using hand hygiene as an example. The Joint Commission Center for Transforming Healthcare has developed targeted solution tools. I'm going to show you the hand hygiene, but there's handoff communications, right side surgery. You look at the WHO patient safety list, and you look at what most international and national patient safety goals are. They've tackled this in creating these tools. Now, we weren't sure whether these were going to work internationally, so we did take them around to 9 organizations in different parts of the world and implemented them to make sure they would work. So there was 14 projects altogether in 9 healthcare organizations in different types of units in the hospital. And the observations about hand hygiene, there was over 8,000 observations entered. And then they got a baseline. The baseline was at 42%, this is aggregate, were actually practicing good hand hygiene. And those hospitals believe they were in the 80s in terms of their compliance with hand hygiene. But based on this observational method of recording actual hand hygiene use, they found it was much lower. Why was it lower? Well, this is the hospitals are the letters across the top, and the numbers are actually the different units in the hospital. So Hospital A had 2 different units. But there you can see the reasons for lack of hand hygiene compliance were different from one unit to the next. This one unit, the follow entry problem is if the person who goes into the patient room before you does not wash their hands or use gel or something, the people that follow usually don't either. So if that's your doctor charging in to go in to see a patient, the nurse and everybody else is going to go right in after them if the doctor didn't clean their hands. So that was a big problem here in one unit, but it was not in the next. Their problems were related to too much stuff in their hands to really or a misunderstanding about the use of gloves or isolation area, or they went in and out and only sometimes. So this shows that there's no uniformity here in terms of the reasons that people don't clean their hands. So this would imply then that for Hospital A, they needed to come up with different solutions for Unit 1 and Unit 2. And that points out the fact that the mechanisms we have currently to gather this type of hand hygiene compliance are probably not amenable to be segregated out. This tool then helps take whatever the contributing factors were then and create a plan to overcome that particular factor. So many of the, as I mentioned, the failures for hand hygiene, the data isn't complete or it's not good enough to tell you what the problem is. Many times inconvenient location, these are the top causes. Ineffective education, lack of accountability, and each of these, you can't bundle all 5 together with one approach. Each one takes a different approach. If you want to go on and look at more about this, it's the Center for Transforming Healthcare. It's part of the Joint Commission enterprise structure. And you can look at the different tools there. We are in the process of bringing those tools, hopefully at no cost, to all of our accredited organizations. At least get the hand hygiene started so that you can begin to test it and see whether it makes a difference in hand hygiene compliance in your organization. So in conclusion, as quality and healthcare evolve, we need to look for the weak points or the gaps in our own organizations and begin to see if we can fill those gaps or we can find good practices in other organizations if we're really going to move quality and patient safety to the next level. And accrediting bodies and standards hopefully will provide guidance to organizations along this journey to higher reliability. Much of what I've talked about here are in the standards of the new 5th edition for the JCI Hospital Accreditation Program in some form or other. Thank you.